"Get out! You're a black woman. I won't treat you." Nurse Rebecca Harrison's voice carried across the pristine emergency department like a death sentence. Behind the reception desk of St. Mary's Medical Center, the most prestigious hospital in the city, she stared down at the woman clutching her chest in obvious pain. Blood pressure 180/110, heart rate 140 bpm. Classic signs of a cardiac event, but Rebecca saw only a young black woman without immediate proof of premium insurance coverage. 2:47 a.m., the quietest hour in emergency medicine. The moment when prejudice could kill and nobody would witness the crime. Have you ever been denied life-saving treatment because someone decided you weren't worth saving? 30 seconds until the security cameras capture everything. 30 seconds until hospital board chairwoman Dr. Victoria Matthews reveals her identity and ends a career built on discrimination. But Nurse Harrison doesn't know that yet. She sees only what her bias allows her to see. The fluorescent lights hummed overhead like electronic vultures, casting harsh shadows across the emergency department's gleaming floors. Dr. Matthews had arrived at her own hospital seeking treatment for chest pains that had awakened her from sleep, driving herself when the symptoms worsened. She wore simple jeans and a Georgetown University sweatshirt, the casual clothes of someone who'd thrown on whatever was closest when medical emergency struck at 10 a.m. Rebecca looked up from her computer screen with the expression of someone interrupted during important work, though she'd actually been scrolling through social media for the past 20 minutes. Her 15 years as an emergency department nurse had hardened her against what she perceived as frequent attempts by uninsured patients to receive free treatment at expensive private hospitals. Do you have insurance cards, photo ID, anything that shows you can pay for treatment here? Rebecca asked, her tone suggesting she already knew the answer would be unsatisfactory. Dr. Matthews reached into her purse with trembling hands, the chest pain intensifying with each movement. Her wallet contained her medical license, hospital board identification, and credit cards with limits that exceeded most people's annual income. But the pain was affecting her coordination, making simple tasks feel monumental. "I have everything you need," she managed to say, fumbling through her wallet. "But I need medical attention now. These symptoms are serious." Rebecca barely glanced at the identification being offered, her attention already shifting to other tasks she considered more important than treating someone she'd prejudged as indigent. The emergency department's policy manual, clearly posted behind her desk, stated that all patients presenting with chest pain must be immediately triaged regardless of insurance status. But policies were often ignored when supervisors weren't watching. "Look, I can see you're in distress, but this is a private hospital," Rebecca said with practiced indifference. "Metro General is only 15 minutes away. They have to treat everyone, and it won't cost you anything." The suggestion was medically dangerous and legally questionable. 15 minutes could mean the difference between successful treatment and permanent heart damage. Metro General was overcrowded, understaffed, and equipped for basic emergency care rather than the advanced cardiac interventions that St. Mary's provided. Dr. Matthews felt another wave of chest pain that made her lean against the reception desk for support. Her medical knowledge told her that time was critical, that delayed treatment could result in irreversible damage or death. But her position as the hospital's board chairwoman remained unknown to the nurse whose discrimination was putting her life at risk. "Please," she whispered, her voice carrying the desperation that came with facing mortality. "I just need someone to look at me, to check my vital signs, to determine if I'm having a heart attack." Rebecca's response revealed the full extent of her prejudice and the dangerous assumptions that guided her patient care decisions. "Ma'am, you're probably just having anxiety or indigestion. Young women like you don't typically have heart attacks. Maybe try some antacids when you get home." The dismissal was medically irresponsible and racially motivated. Studies showed that black women were significantly more likely to have their cardiac symptoms minimized or misdiagnosed, leading to delayed treatment and higher mortality rates. Rebecca was perpetuating deadly healthcare disparities through her individual bias and systemic discrimination. Behind the emergency department's automated doors, Dr. James Chen was completing his overnight shift as attending physician. His 12 years of emergency medicine had taught him to recognize genuine medical emergencies, and something about the commotion at the reception desk caught his attention. Through the glass partition, he could see a woman in obvious distress being turned away rather than triaged. "Rebecca, what's the situation with that patient?" Dr. Chen asked, approaching the reception desk with growing concern. "Nothing urgent," Rebecca replied quickly, not wanting her discriminatory actions scrutinized by medical staff. "Just someone looking for free treatment. I'm directing her to Metro General where she belongs." Dr. Chen looked at Dr. Matthews, noting her pallor, labored breathing, and the way she clutched her chest, all classic presentations of acute cardiac distress. His medical training overrode administrative protocols as he moved toward the patient who was being denied care. "Ma'am, I'm Dr. Chen," he said, his voice carrying the authority and compassion that exemplified excellent emergency medicine. "Can you describe your symptoms for me?" Dr. Matthews looked up at him with relief, recognizing competent medical care when she encountered it. "Doctor, I'm experiencing severe chest pressure, radiating to my left arm. Shortness of breath, diaphoresis, nausea. Onset was sudden about 45 minutes ago." The symptom description was textbook myocardial infarction delivered with medical precision. That should have immediately identified Dr. Matthews as a healthcare professional. Dr. Chen's expression grew serious as he recognized the potential severity of her condition. "We need to get you into triage immediately," he told her, then turned to Rebecca with barely contained anger. "Why wasn't this patient triaged immediately? These are obvious cardiac symptoms requiring immediate evaluation." Rebecca's face flushed with embarrassment and defensive anger. "Doctor, she doesn't have proper insurance verification. I was following protocol by directing her to Metro General." Protocol? Dr. Chen's voice carried the authority of someone who'd written and implemented emergency department policies. EMTALA requires that we evaluate and stabilize all patients presenting with emergency medical conditions regardless of ability to pay. You're violating federal law. The Emergency Medical Treatment and Labor Act was clear and unambiguous. Hospitals receiving Medicare funding could not turn away patients based on insurance status or ability to pay. Rebecca's actions weren't just discriminatory. They were illegal and exposed the hospital to significant liability. Dr. Matthews felt another surge of chest pain that made her gasp audibly. The stress of being denied treatment was exacerbating her cardiac symptoms, creating a dangerous cycle where discrimination was literally threatening her life. Her medical knowledge told her that every minute of delay increased the risk of permanent heart muscle damage. "Dr. Chen," she managed to say between labored breaths, "I need to tell you something important about who I am." But before she could reveal her identity as the hospital's board chairwoman, the emergency department's automatic doors burst open. Paramedics rushed in with a trauma patient from a multi-vehicle accident, their urgent calls for assistance drawing Dr. Chen's immediate attention away from the discrimination unfolding at the reception desk. "Ma'am, please wait just a moment," Dr. Chen told Dr. Matthews, his medical priorities pulled between multiple critical patients. "I'll be right back to get you properly triaged." Left alone with Rebecca again, Dr. Matthews reached into her purse one more time, this time retrieving her hospital board identification card that clearly stated her position as chairwoman of the board of directors. Her hands shook as she placed it on the reception desk, the plastic card containing the authority to fire every employee in the building. "Nurse Harrison," she said, reading the name tag with effort as another wave of chest pain hit her. "I need you to look at this identification very carefully." Rebecca glanced down at the ID card with the same dismissive attitude she'd shown toward everything else Dr. Matthews had presented. Hospital board positions seemed impossibly remote from her daily reality, and she assumed the identification was either fake or belonged to someone else. "Ma'am, anyone can get fake IDs made," Rebecca said with condescension that revealed her complete inability to recognize authority when it didn't match her preconceived notions. "I need real insurance cards and government-issued photo identification." The response demonstrated the depth of Rebecca's prejudice. She was willing to assume that a black woman presenting with cardiac symptoms was more likely to possess fraudulent identification than legitimate medical insurance. Her bias had created tunnel vision that prevented her from processing information that contradicted her assumptions. Dr. Matthews pulled out her driver's license, her medical license from the state board, and her hospital employee badge that granted her access to every secured area of the facility. The collection of credentials should have immediately identified her as not just a patient, but as the single most powerful person in the entire hospital system. "Rebecca," she said, using the nurse's first name with a familiarity that came from having hired her and approved her salary increases over the past 5 years. "Look at these credentials, look at my name, look at my position." Rebecca's glance was cursory and dismissive, her predetermined conclusions preventing her from processing the evidence in front of her. She had decided that Dr. Matthews was an uninsured patient seeking free treatment, and no amount of contradictory evidence would penetrate her bias. "Look, I don't have time for this," Rebecca snapped, her frustration growing as her discriminatory actions faced persistent challenge. "Either show me valid insurance or go to Metro General. I'm not processing fake documents." The conversation was being recorded by security cameras that captured every word, every dismissive gesture, every moment of discrimination that would soon become evidence in lawsuits, termination hearings, and training seminars about health care bias. But Rebecca remained oblivious to the consequences building around her prejudice decisions. Dr. Matthews felt her chest pain intensifying to the point where she could barely stand upright. The stress of fighting for basic medical care while experiencing a cardiac event was creating a perfect storm of physical and emotional trauma that could prove fatal without immediate intervention. "I'm going to ask you one final time," she whispered, her voice weak but carrying the authority that had led board meetings and hospital acquisitions. "Please provide me with emergency medical treatment. Please look at my identification. Please understand that you're making a terrible mistake." Rebecca's response revealed the full extent of her prejudice and the dangerous mindset that had guided her nursing practice for years. "Ma'am, you need to accept that this isn't the place for people like you. We serve a different type of clientele here. Metro General will take better care of your ... situation." The words hung in the air like toxic gas, their racist implications clear to anyone who understood the coded language of healthcare discrimination. Rebecca had revealed her belief that Black patients belonged in different, lesser facilities rather than receiving equal treatment at prestigious hospitals. Dr. Chen returned from the trauma bay, having stabilized the accident victim and delegated ongoing care to the surgical team. His attention immediately returned to Dr. Matthews, whose condition had visibly deteriorated during his absence. The pallor, diaphoresis, and obvious distress indicated a medical emergency requiring immediate intervention. "What's happening here?" he demanded, noting the tension between Rebecca and the patient who clearly needed immediate medical attention. "Doctor, I've been trying to explain that this patient needs to be treated elsewhere," Rebecca said, attempting to maintain her discriminatory position even in the face of medical authority. "She doesn't meet our admission standards." Dr. Chen's expression darkened with anger at the blatant violation of medical ethics and legal requirements he was witnessing. "Rebecca, there are no admission standards for emergency treatment. EMTALA requires that we evaluate all patients. Your actions are illegal and medically dangerous." He turned to Dr. Matthews with professional compassion and growing concern about her deteriorating condition. "Ma'am, I apologize for this inexcusable delay in your care. Let's get you into a treatment room immediately." Dr. Matthews nodded weakly, but before following Dr. Chen, she placed her hospital board identification directly in front of Rebecca one final time. The plastic card gleamed under the fluorescent lights, its official seal and clear text identifying her as the most powerful person in the building. "Nurse Harrison," she said, her voice barely audible but carrying the weight of absolute authority, "I am Dr. Victoria Matthews, chairwoman of the board of directors of this hospital. You have just denied emergency medical treatment to your ultimate supervisor. You have violated federal law, hospital policy, and basic human decency." Rebecca's face went white as the identification finally penetrated her prejudiced assumptions. The name Victoria Matthews was legendary in the hospital system, the youngest board chairwoman in the institution's history, the architect of its expansion into a regional medical network, the person whose decisions affected every employee's career and livelihood. "Dr. Matthews," Rebecca whispered, her voice cracking as the full magnitude of her mistake became clear. But ... you're... I didn't know. You didn't know because you decided what I was before you looked at who I am, Dr. Matthews replied, her words cutting through Rebecca's shock like surgical instruments. You saw a black woman and assumed indigence. You saw casual clothes and assumed worthlessness. You saw someone in distress and chose discrimination over compassion. Dr. Chen stood frozen between professional duty to his patient and growing awareness that he was witnessing a career-ending moment for one of his colleagues. The nursing staff who had overheard the confrontation began gathering at a respectful distance, understanding that something momentous was unfolding in their department. Dr. Matthews, please, Rebecca begged, her earlier arrogance replaced by desperate fear for her career and livelihood. I was just following protocols. I didn't mean any harm. I can explain everything. You can explain to hospital administration, federal investigators, and civil rights attorneys, Dr. Matthews said, accepting Dr. Chen's assistance as they moved toward the treatment area. Right now, I need emergency cardiac care. Later, we'll address the systematic discrimination that nearly killed me tonight. The treatment room doors closed behind Dr. Matthews and Dr. Chen, leaving Rebecca alone with the devastating realization that her prejudice had just destroyed everything she'd worked for over 15 years of nursing. The security cameras had recorded every discriminatory word, every dismissive gesture, every violation of federal law and hospital policy. Within minutes, word spread through the hospital that the board chairwoman had been denied emergency treatment by a nurse whose bias had nearly caused a preventable tragedy. Dr. Chen's preliminary examination confirmed acute myocardial infarction requiring immediate intervention, a heart attack that could have been fatal if treatment had been delayed much longer. The cardiac catheterization lab was activated for emergency intervention, with Dr. Sarah Kim, the hospital's leading interventional cardiologist, rushing in to perform the life-saving procedure that cleared blocked arteries and restored blood flow to Dr. Matthews' heart muscle. The same advanced technology that Rebecca had tried to deny her access to ultimately saved her life. Hospital Administrator Robert Johnson received the emergency call at 3:47 a.m., his sleep interrupted by news that would trigger the most significant crisis in the hospital's recent history. The board chairwoman had been discriminated against by hospital staff, denied emergency treatment, and forced to fight for her life while facing racial bias from the very people sworn to heal. Get me complete security footage of the incident, Johnson told his assistant over the phone. Contact our legal department, human resources, and public relations team. Schedule an emergency board meeting for later today. And find out everything about Nurse Rebecca Harrison's employment history. By dawn, the story was spreading through the hospital like wildfire. Nurses, doctors, technicians, and administrative staff couldn't believe that one of their colleagues had denied treatment to the hospital's most powerful leader. The incident raised uncomfortable questions about how many other patients had been discriminated against when no cameras were watching. Rebecca sat in the employee lounge, her career effectively over but the full consequences not yet implemented. She'd called in sick for her remaining shifts, unable to face colleagues who now knew about her discriminatory actions. Her 15 years of nursing experience, her accumulated vacation time, her pension benefits, everything was in jeopardy because of one night's prejudice. Dr. Matthews recovered from her cardiac procedure with no permanent heart damage, the successful intervention proving that prompt medical care could indeed save lives when discrimination didn't delay treatment. From her hospital bed, she began planning the systematic changes that would prevent other patients from experiencing what she'd endured. Her first call went to civil rights attorney David Rodriguez, a specialist in healthcare discrimination who had successfully prosecuted similar cases across the nation. David, I need comprehensive legal action against discriminatory practices in emergency medicine. I have video evidence, witness testimony, and personal experience of life-threatening bias. The second call reached Dr. Angela Washington, director of the National Association for Healthcare Equity, whose organization had documented thousands of cases where racial bias affected medical treatment. Angela, we need to use this incident to create systematic change in hospital policies nationwide. The third call connected her with investigative journalist Maria Santos, whose exposes of healthcare discrimination had won Pulitzer Prizes and changed hospital practices across the country. Maria, I have a story that will demonstrate how racial bias literally kills patients when healthcare workers prioritize prejudice over professional duty. Within 48 hours, the incident had triggered multiple investigations that would reshape healthcare delivery far beyond St. Mary's Medical Center. The Department of Health and Human Services launched a federal inquiry into discriminatory practices. The State Medical Board initiated reviews of hospital policies. Civil rights organizations filed formal complaints with every relevant authority. Rebecca received termination papers delivered by certified mail, the official language documenting her dismissal for cause due to violation of federal anti-discrimination laws, breach of professional nursing standards, and conduct detrimental to patient safety. She was barred from re-employment at any facility within the hospital network. But Dr. Matthews wasn't satisfied with individual punishment when systematic problems required systematic solutions. Her recovery period was spent designing comprehensive reforms that would address health care bias at its roots rather than simply responding to its symptoms after damage was done. The first initiative established bias recognition training for all hospital employees, mandatory programs that helped staff identify their unconscious prejudices and understand how those biases affected patient care. The training used Dr. Matthews' experience as a case study, showing how discrimination could literally kill patients when medical professionals prioritized assumptions over assessments. The second program implemented patient advocacy systems that provided immediate escalation procedures when patients felt they were receiving discriminatory treatment. Trained advocates, available 24/7, could intervene in situations where bias was affecting care quality, ensuring that no patient would face what Dr. Matthews had experienced alone. The third reform required demographic auditing of all emergency department decisions, with monthly reports analyzing whether patients of different races received equal treatment in terms of wait times, pain management, diagnostic testing, and admission rates. Data transparency would reveal bias patterns before they became life-threatening discrimination. The fourth change established community oversight boards with authority to investigate discrimination complaints and recommend policy changes. Board members included civil rights advocates, community leaders, and former patients who understood health care bias from personal experience. 6 months after the incident, St. Mary's Medical Center had become a national model for addressing healthcare discrimination. Its transformation demonstrating that systematic change was possible when leadership committed to meaningful reform rather than cosmetic adjustments. Rebecca, meanwhile, struggled to find employment in healthcare, her termination for discrimination following her to every potential job. The nursing profession's small community meant that word spread quickly about her actions, and administrators were reluctant to hire someone whose bias had nearly killed a patient. The experience forced Rebecca to confront the prejudices that had guided her nursing practice for years, though genuine transformation proved difficult for someone whose biases were deeply ingrained. Her required counseling sessions revealed childhood experiences and social influences that had shaped her assumptions about race, class, and medical worthiness. Dr. Matthews returned to her role as board chairwoman with renewed commitment to health care equity, her personal experience with discrimination providing powerful motivation for systematic change. She established the Matthews Foundation for Healthcare Justice, providing funding for bias research, discrimination victims' legal support, and innovative programs promoting medical equality. The Foundation's first major initiative created the Code Respect Protocol, a system allowing any patient or family member to immediately summon a patient advocate when they experienced discriminatory treatment. The protocol was adopted by over 200 hospitals nationwide within 2 years, preventing countless incidents of health care bias. The second program established the Health Care Bias Documentation Project, a national database tracking discriminatory incidents across medical facilities. The anonymous reporting system allowed healthcare workers to document bias they witnessed without fear of retaliation, creating comprehensive data about discrimination's prevalence in medical settings. The third initiative funded medical school curricula addressing implicit bias in health care, ensuring that future doctors and nurses received training in recognizing and preventing discriminatory treatment. The program reached over 15,000 medical students in its first 3 years, fundamentally changing how healthcare professionals understood their responsibilities to all patients. 1 year after the incident, Dr. Matthews spoke at the American Medical Association's annual convention. Her keynote address titled "When Prejudice Nearly Killed the Board Chair: Personal Experience and Systematic Solutions in Healthcare Discrimination." "I nearly died because a nurse saw a black woman and assumed I didn't deserve the same emergency care provided to other patients," she told the audience of 3,000 medical professionals. "My experience wasn't unique. It was typical of what happens when healthcare workers carry racial bias into life or death decisions." She shared statistics showing that black patients were significantly more likely to have their pain underestimated, their symptoms dismissed, and their emergency needs minimized compared to white patients with identical conditions. The data revealed that her experience was part of a larger pattern that killed thousands of patients annually. "The nurse who discriminated against me didn't see herself as racist," Dr. Matthews continued. "She saw herself as protecting hospital resources from undeserving patients. But her assumptions about who deserved care nearly cost me my life and definitely compromised countless other patients over her 15-year career." The address became a viral video viewed over 2 million times, its powerful message reaching healthcare workers, patients, and policymakers across the globe. Medical schools began requiring students to watch the presentation as part of their ethics training, ensuring that future healthcare providers understood discrimination's deadly consequences. Rebecca watched the convention address from her small apartment, her former colleagues' words carrying the weight of truth that forced uncomfortable self-reflection. The woman she nearly killed through prejudice was now saving other lives by preventing healthcare discrimination, transforming personal trauma into systematic change. 2 years post-incident, the reforms triggered by Dr. Matthews' experience had spread far beyond St. Mary's Medical Center. The Matthews Protocol for addressing healthcare bias became standard policy at major medical centers nationwide, while the bias training programs she developed were implemented in nursing schools across the country. The legal consequences continued unfolding as well. Rebecca faced civil rights lawsuits seeking damages for her discriminatory actions, with Dr. Matthews' case serving as the foundation for broader class action suits brought by other patients who'd experienced similar bias. The financial penalties sent clear messages that healthcare discrimination carried significant costs. But perhaps the most powerful change was cultural. The incident had sparked national conversations about healthcare bias that forced medical professionals to examine their own assumptions and practices. Patient advocacy groups used Dr. Matthews' story to demand accountability, while medical organizations implemented policies ensuring equal treatment regardless of race, class, or appearance. Medical conferences began featuring panels on healthcare discrimination, with speakers sharing research about bias in pain management, diagnostic testing, treatment recommendations, and emergency care. The discussions revealed that Dr. Matthews' experience was part of a systematic problem requiring systematic solutions rather than individual punishment. The community clinic where Rebecca now worked became an unexpected laboratory for redemption and transformation. Working with the very population she'd previously discriminated against forced her to confront her biases daily, while close supervision ensured that her prejudices couldn't harm vulnerable patients. Her supervisor, Dr. Patricia Williams, was a black physician who'd experienced healthcare discrimination throughout her own medical career. The irony wasn't lost on anyone that Rebecca now reported to someone she might previously have assumed was unqualified for medical leadership. Rebecca, Dr. Williams said during one of their monthly supervision meetings, "Your experience with Dr. Matthews could have destroyed your nursing career completely. The fact that you're here, working with underserved patients, represents a second chance that many people don't receive." The supervision sessions became therapeutic spaces where Rebecca could examine her prejudices honestly, understanding how childhood experiences, social influences, and professional culture had shaped her discriminatory assumptions. The work was uncomfortable but necessary for genuine transformation. "I was raised to believe that some people deserved better health care than others," Rebecca admitted during one particularly difficult session. "I thought private hospitals should serve private patients and that public hospitals existed for everyone else. I didn't see how that thinking could kill people." Dr. Williams nodded with the patience of someone who'd witnessed many colleagues struggle with bias recognition. "Rebecca, the tragedy isn't just that you nearly killed Dr. Matthews through discrimination. The tragedy is how many other patients you probably harmed over 15 years when your biases affected their care. The realization was devastating but necessary. Rebecca's prejudices hadn't begun or ended with Dr. Matthews. They'd influenced countless patient interactions, probably contributing to delayed diagnoses, inadequate pain management, and substandard care for patients she deemed less deserving of attention. 3 years after the incident, Dr. Matthews published a comprehensive memoir titled Healing the Healers: My Fight Against Healthcare Discrimination, which became required reading in medical programs nationwide. The book detailed not only her personal experience but also the systematic changes needed to address bias in medical settings. The memoir's most powerful chapter described her recovery period when she learned about other patients who died from discriminatory care. Heart attacks misdiagnosed as anxiety, strokes dismissed as drug-seeking behavior, cancer symptoms ignored because healthcare workers assumed certain patients were exaggerating their pain. My privilege as a board chairwoman saved my life, she wrote. I had the power to demand treatment, the resources to fight discrimination, and the authority to create systematic change. But thousands of other patients lack those advantages. They suffer and die in silence while bias masquerades as medical judgment. The book sparked congressional hearings on healthcare discrimination, with Dr. Matthews testifying before Senate committees about the need for federal oversight of medical bias. Her testimony contributed to legislation requiring hospitals to track demographic data on treatment decisions and report disparities to federal authorities. Rebecca read the memoir from cover to cover, finding her own story told with accuracy but also with compassion that she probably didn't deserve. Dr. Matthews had portrayed her not as a monster but as a person whose biases had created monstrous consequences, a distinction that offered hope for redemption through genuine change. The community clinic work was gradually transforming Rebecca's understanding of patient care and professional responsibility. Working with uninsured and underinsured patients forced her to confront her assumptions about medical worthiness, while collaboration with diverse colleagues challenged her prejudices about professional competence. Dr. Williams noticed improvement in Rebecca's patient interactions over time, her initial discomfort evolving into genuine compassion for vulnerable populations. The transformation wasn't complete. Prejudices formed over decades couldn't be eliminated in months, but progress was evident in daily patient encounters. Rebecca, one patient told her during a particularly busy shift, "You're the only nurse who's ever listened to me when I described my pain. Other healthcare workers act like I'm lying or exaggerating. Thank you for believing me." The comment struck Rebecca powerfully because she recognized her former self in the description of dismissive healthcare workers who didn't believe certain patients deserved proper attention. Her own biases had probably caused similar pain for countless patients over her career. For years after the discrimination incident, the reforms it triggered had created measurable improvements in healthcare equity across the nation. Studies showed reduced disparities in pain management, emergency treatment, and diagnostic testing as bias training programs helped healthcare workers recognize and address their prejudices. Dr. Matthews received the Presidential Medal of Freedom for her contributions to healthcare justice, the ceremony recognizing her transformation of personal trauma into systematic change that saved countless lives. In her acceptance speech, she credited the discrimination she'd experienced with providing motivation for reforms that might not have been possible otherwise. Sometimes our worst experiences become our greatest contributions, she said, addressing a national audience that included millions of healthcare workers. The nurse who nearly killed me through prejudice inadvertently sparked changes that will save thousands of other patients from similar discrimination. The ceremony was broadcast live to medical facilities nationwide, with many hospitals organizing viewing parties where staff could discuss bias in their own institutions. The visibility helped normalize conversations about healthcare discrimination that had previously been avoided or minimized. Rebecca watched the Medal of Freedom ceremony from her apartment, feeling a complex mixture of shame, regret, and grudging respect for the woman whose life she nearly ended through prejudice. Dr. Matthews had chosen transformation over revenge, education over litigation, systematic change over individual punishment. 5 years post-incident, Rebecca had completed her probationary period at the community clinic and earned permanent employment status, her performance evaluations showing consistent improvement in patient care and cultural sensitivity. The transformation wasn't complete, but it was genuine. Her interactions with patients now reflected professional respect rather than discriminatory assumptions. Dr. Williams recommended Rebecca for advanced bias training certification, allowing her to help train other healthcare workers in recognizing and preventing discriminatory care. The irony was profound. The nurse who'd nearly killed a patient through prejudice was now helping prevent similar incidents. Rebecca, Dr. Williams said during their final supervision meeting, "Your journey from discrimination to advocacy demonstrates that people can change when they're willing to confront uncomfortable truths about themselves. Your experience could help other healthcare workers examine their own biases before those biases harm patients." The training program Rebecca developed was titled The Cost of Bias When Prejudice Becomes Life-Threatening, and it used her own discrimination against Dr. Matthews as a case study in how healthcare bias could kill patients. The program was adopted by nursing schools and medical facilities across the region. Dr. Matthews agreed to participate in some training sessions, her presence lending credibility and power to discussions about healthcare discrimination. The interactions between victim and perpetrator provided unique insights into both the causes and consequences of medical bias. "Nurse Harrison nearly killed me because she assumed a black woman couldn't afford quality health care," Dr. Matthews would tell training participants. Her prejudices created tunnel vision that prevented her from processing evidence that contradicted her assumptions. This kind of bias kills patients every day in healthcare settings across America. The training sessions were emotionally difficult but professionally transformative for participants who'd never considered how their own biases might affect patient care. Many healthcare workers admitted to having assumptions similar to Rebecca's, though few had acted on those prejudices so dramatically. 6 years after the incident, the changes it had triggered were measurable in patient satisfaction scores, equity metrics, and health outcomes across demographic groups. Hospitals that had implemented the Matthews Protocol showed significant improvements in providing equal care regardless of patient race, class, or appearance. The story became a permanent part of medical education, taught in nursing schools, medical schools, and healthcare administration programs as an example of how individual bias could create systematic harm. Students learned to recognize discrimination disguised as medical judgment and understand their professional responsibility to provide equal care to all patients. Rebecca's transformation from discriminatory nurse to bias prevention advocate demonstrated the possibility of redemption through accountability, education, and genuine commitment to change. Her presentations to healthcare workers carried unique authority because she spoke from personal experience about the consequences of medical prejudice. "I nearly killed Dr. Matthews because I saw her race before I saw her humanity," Rebecca would tell audiences of nurses and doctors. "My assumptions about who deserved quality health care almost cost a life and definitely compromised my ability to provide professional care to all patients." The presentations weren't easy for Rebecca, requiring her to repeatedly admit mistakes that had nearly proven fatal. But the discomfort was necessary for genuine transformation and essential for helping other healthcare workers recognize similar biases in their own practice. 7 years later, Dr. Matthews had been promoted to Chief Executive Officer of the Regional Hospital Network, her leadership transforming not just individual facilities but entire healthcare systems. The discrimination she'd experienced had motivated reforms that saved thousands of lives and prevented countless other patients from experiencing similar bias. The memoir she'd written became a classic text in medical ethics courses, its personal narrative combined with systematic analysis providing powerful insights into healthcare discrimination and effective responses to medical bias. Students across the nation learned about professional responsibility through her example. Rebecca had become a nationally recognized expert in healthcare bias prevention, her story of transformation inspiring other healthcare workers who'd recognized their own discriminatory assumptions. Speaking engagements took her to medical conferences, nursing conventions, and healthcare facilities across the country. The community clinic where she worked had become a model for equitable healthcare delivery, its diverse staff and comprehensive bias training programs serving as examples for other facilities seeking to address discrimination in medical settings. Patient satisfaction scores consistently ranked among the highest in the region. The nurse who discriminated against me became an advocate for healthcare equality, Dr. Matthews often said when discussing the long-term consequences of that night in the emergency department. Her transformation demonstrates that even our worst failures can become contributions to justice when we're willing to confront uncomfortable truths about ourselves. The lesson had spread far beyond healthcare into other professional settings where bias could affect service delivery, employment decisions, and treatment of vulnerable populations. Police departments, schools, social service agencies, and corporations had adopted similar bias recognition training programs. 8 years after the discrimination incident, its impact continued rippling through American healthcare in ways neither Dr. Matthews nor Rebecca could have anticipated. The systematic changes triggered by one night's prejudice had fundamentally altered how medical professionals understood their responsibilities to all patients. Medical schools now require courses in healthcare equity as part of core curricula, with students learning to recognize and prevent discriminatory care from the beginning of their professional training. The programs used Dr. Matthews' experience as a foundational case study in understanding bias consequences. Nursing programs implemented similar requirements, with Rebecca's story serving as a powerful example of how prejudice could destroy careers and compromise patient care. Her transformation from discriminatory nurse to bias prevention advocate provided hope that even deeply ingrained prejudices could be addressed through education and accountability. Healthcare facilities across the nation had adopted patient advocacy systems modeled on the protocols Dr. Matthews had developed, ensuring that discrimination complaints received immediate attention from trained professionals who understood bias recognition and intervention strategies. The legal consequences of healthcare discrimination had also evolved, with civil rights attorneys using Dr. Matthews' case as precedent for pursuing damages against medical facilities and individual healthcare workers whose bias had harmed patients. The financial penalties created powerful incentives for addressing discrimination proactively. Rebecca's training programs had reached over 50,000 healthcare workers in 8 years, her presentations consistently rated among the most impactful bias prevention education available to medical professionals. The irony remained powerful. The nurse whose discrimination had nearly killed a patient was now preventing similar incidents through her advocacy work. The community clinic had expanded its services significantly, receiving federal grants and private donations that recognized its innovative approaches to equitable healthcare delivery. The facility served as a training site for medical students and nursing students learning about bias-free patient care. Dr. Williams had been promoted to regional medical director, her success in supervising Rebecca's transformation making her a sought-after expert in healthcare worker rehabilitation and bias prevention education. Her approach to addressing discrimination through education rather than just punishment had influenced disciplinary policies across the medical profession. 10 years after that night in the emergency department, Dr. Matthews stood before the World Health Organization's Global Health Assembly, delivering a keynote address on healthcare discrimination that reached medical professionals in 194 countries. Her personal experience had become a universal lesson about bias prevention.